Hi, everybody. I think we still have some people coming on in, but I know we also have a lot of people logging in remotely from our different clinics, so we're going to get started. I don't know everyone here all the time, so just real quick, I'm Mike Friedman, Director of Strategic Programming and part of the Education Leadership for PM&R. And Dr. Mayer, who usually does this, is, I think, at Bayview remote, so he can see and hear us. Don't say anything mean about him. So real quick, usually we start off with either a small platform, research platform, or a quality improvement project. Today, Julie Quinn from our pediatric group was going to do that. She had a family issue, and so we have to reschedule. We're going to do that in the future. So we're going to just start off with the main event. Dr. Carol Courtney is PT, Ph.D., ATC. Is a clinical professor and director of post-professional fellowship in orthopedic manual physical therapy at the University of Illinois at Chicago. She received her Bachelor of Science in Physical Therapy from Washington University in St. Louis and her Master of Science from the University of South Australia and Louisiana State, and a Ph.D. from the University of Miami. Dr. Courtney is a licensed physical therapist and athletic trainer and has been recognized as a fellow of the American Academy of Orthopedic Manual Physical Therapists. Dr. Courtney has clinical expertise in the management of chronic musculoskeletal pain and sports injury. Her research investigates the effects of knee joint injury and osteoarthritis on pain processing and joint function, as well as modulation of pain mechanisms through manual therapy interventions. She has over 100 peer-reviewed publications, book chapters, and conference presentations, and has presented both nationally and internationally on her research. So please, if everyone could join me in welcoming Dr. Courtney. Thank you.
Okay, thanks for that nice introduction. Everybody can hear me okay? Yeah? So as you said, I'm going to talk today about pain mechanisms associated with knee OA. And, I've mentioned to a couple people beforehand that really I started off looking at sports injury and wondering why motor control mechanisms changed after sport injury. And it's been a natural progression to see how an acute joint injury can lead to osteoarthritis. So I'll kind of take you on that journey today. So here's the objectives. You have those, and I have no disclosures. So we know that chronic pain's an epidemic in today's world, and it's been estimated that the prevalence of chronic pain in U.S. adults is at somewhere between 30 and 43%. And if you do the math on that, that's a significant number of people. Studies in the UK have suggested similar statistics. And the consequences of this are really staggering if you think about it. And they include disability, reduced quality of life, increased risk of hospitalization, institutionalization, and then mortality. And there's another epidemic in the U.S., and we know about that as well, and that's opioid-related abuse and addiction. And I will just briefly mention this. This is a study by DART in the New England Journal of Medicine in 2015. And very simply, it's just showing how the number of opioid prescriptions dispensed increased over a 10-year period. And so now the modern view is we're starting to think about what are some non-pharmacological ways to address chronic pain. But before we talk about that, I'll just briefly mention some of the contributing factors and risk factors to chronic pain. And again, this is just a sample of some of those. And I'll talk about social, physiological, and psychological factors. In terms of social factors, we know that tenuous housing status, tenuous employment status can be a contributor. And in fact, in some of the groups I worked with at the U of I, on the team will be someone like a lawyer who's helping to make sure that the person has housing. So we don't often think of that as one of the team members to treat chronic pain, but having housing can be really, really key. Also are low family income, low educational levels, social isolation and recent divorce, separation or death of a spouse. And then a big factor is physical or sexual abuse. And the studies suggest that this can be a major factor in chronic pain. However, clinically, we often don't screen for that because we may be uncomfortable with that question. But again, if that factor's there, that may be something that needs to be addressed. Physiological contributing factors and risk factors may include poor sleep quality, and I'll talk more about this later in the talk, menopause, and then number of comorbidities is a huge factor. And then psychological factors, I'll just briefly address this. Persons with chronic pain experience a range of psychological impairments that include anxiety, depression, anger, hostility, impaired self-esteem, and then impaired general emotional functioning. And in the study by Burke in 2015, he suggested that depression and chronic pain may co-occur in up to 80% of individuals with these disorders. Now, he's not suggesting that one causes the other, but the fact that they could go both directions. You could be depressed and that can contribute to chronic pain, or you can have chronic pain and that can contribute to depression. So in my program, I'm a big advocate of use of pain diagrams. We know that location of pain can be a powerful driver of hypothesis generation. And so when you see a client and they've got medial knee pain, it's very easy to hypothesize of what could be the cause of that pain. But I always like to say a lot of our patients don't look like this, right? More often they look like this. And they don't just have knee pain, but they've got back pain, and they've got headaches, they've got weird sensations, tingling sensations. And this can lead to a couple issues. One, it can be very confusing, especially to your novice clinician. And it can lead to, one, a very nonspecific diagnosis, like low back pain, which really, if you think about it, that's not a diagnosis at all. The other thing is it can lead to compartmentalizing the patient, meaning like they're starting to hear a lot of information coming in. They say, I'm not going to hear about that today. Today I'm going to look at your knee. And that's an error, because really with chronic pain, we have to have a holistic view of what's going on with that patient before we dive into what we're going to try to intervene with. I would suggest you do that this is a pattern, and that pattern is chronic pain. And there can be several factors that kind of start to raise our antennas that chronic pain is the issue. And we'll talk about those today. Just briefly, the emphasis in physical therapy, and to be honest, all of medicine, is now to take a pain mechanisms approach to patient management. And so this incorporates and it builds on the biopsychosocial. It includes both the pathobiology, psychosocial factors, and then especially in rehab, that movement system impairments. It can include both the source of pain and contributing factors. And then the whole idea is when you identify those factors that you then choose treatments that address that specific factor. And we'll talk about that. So this is just what I had said, use specific interventions to address the specific mechanism. So here's my simple example of that. Your patient comes in and they've had a whiplash disorder and they have high, severe pain. They're not sleeping at night. Well, one of the key things you might want to do is really work on getting them sleeping through the night. We know that sleep disorders can impair your ability to inhibit pain. And so they're really ramped up, but if you can try to get them sleeping, maybe that can be one mechanism that you can try to address. So I'm going to just, now a lot of this may be review for some of you, but I'm going to briefly kind of go through pain mechanisms kind of from a musculoskeletal point of view. And then from that, kind of address some of the clinical factors we see that kind of are indicators of chronic pain. So, what is sensitization? Is actually neuroplasticity. And I always say this because really it wasn't that long ago that we really had a hardwired sort of thinking toward nociception, meaning that you apply a stimulus, like the little naked boy puts his foot in the fire, he feels pain, he takes the foot out of the fire, and he doesn't feel pain. But what we've learned is that the nervous system can learn, so that the next time the nervous system experiences that stimulus, they, figuratively says, I know this stimulus, and I know the answer, and that's pain. And so they experience pain more readily. So let's just talk about a typical joint injury, and I'll use a simple example of the lateral ankle sprain. And so say you tear your anterior talofibular ligament. So what happens? Well, you get a release of inflammatory mediators, and what that inflammatory soup does is that sensitizes the nociceptors that are innervating that damaged tissue. And so that's considered peripheral sensitization. And what can occur then, what we find clinically, is primary hyperalgesia. And really, that's just simply defined as an increased nociceptive response. And so this peripheral sensitization is defined as a stimulus-evoked plasticity of the nociceptor. And when these inflammatory mediators bind to that receptor, it'll cause a decreased threshold to elicit a response and then an increased excitability of that primary afferent. And so I would suggest to you, clinically, we're often looking for primary hyperalgesia. We often overpressure and say, is that painful? Or we twist that ankle or perform tests. We're looking for primary hyperalgesia. The key thing with primary hyperalgesia is, one, it is restricted to the site of injury. Now, this is important because if there's primary hyperalgesia, there's secondary hyperalgesia. So this is the pain you feel right where the anterior talofibular ligament is. So that painful response is primary hyperalgesia. The other thing is that it requires ongoing stimulus for maintenance. So once the ligament heals, primary hyperalgesia goes away. But let's just say you don't get off that ankle, or you send the athlete out and you say, oh, let's just keep playing, and they sprain their ankle again and again, or maybe they're just playing on an injured ankle. What can happen then is you've got this continued input to the spinal cord, and so you can get central sensitization. And again, like I said, this can occur with repetitive input or maybe even just one intense noxious event. And again, this can happen at secondary and tertiary levels, but it is characterized by an increased excitability of those pathways, and we're going to talk about what evidence we have for that. And then the other side of the coin is a descending or a decrease in descending inhibition, and we'll talk about both of these. So how do we identify that patient with centrally mediated pain? I'll just talk a couple slides about some of our work, our laboratory work, that we've done that have looked at central sensitization from that point of view. As you know, in animal model research, it's very common to look at the withdrawal reflex as an outcome for some of those pain measures. So with the rat or mouse, they're using a monofilament to see, what threshold it takes to elicit that withdrawal reflex. Well, we can do this also in humans. And what we do is we apply a painful stimulus, a very painful stimulus, delivered to the skin through a very small electrode, typically in the arch of the foot or maybe at the sural nerve. And then what we look at is the threshold to elicit the flexor withdrawal reflex. And just a reminder, the flexor withdrawal reflex is an increased excitability of the flexor reflex and an inhibition of the extensors. And I'll talk a little bit more about why my interest in that was, just briefly, because when we think of ACL injury or when we think of knee OA, they often have quadricep inhibition. So that was one of our early reasons for looking at this reflex. And at this time, to be honest, not very many people had thought to look at this reflex in people outside the neurological populations or in musculoskeletal populations. And what we found was that that in people with moderate to severe knee OA, they had a decreased threshold to elicit that reflex. And the interesting thing that we also found was often these people, yes, they had severe pain, but they would be sitting and we'd say, "What's your resting pain?" And they said it was 0. But that didn't matter. They still had this heightened reflex. And so resting pain is clearly not the best measure to capture what was going on with this patient population. And I just put this slide up here to mention that there's been other studies that have also looked at the flexor withdrawal reflex as a laboratory measure of central sensitization. Because a decrease in that threshold to elicit the response is an indication of excitability of those nociceptive pathways. You'll see that we also, I had done quite a bit of research in ACL rupture, and after performing the knee OA research, it got me thinking that maybe I needed to go back to the ACL population. Because again, I was very interested in why these patients had so much problems with giving way, quadricep inhibition. So we went back to subjects with ACL deficiency, and we also found that in this population that nociceptive reflex was hyperexcitable on the injured limb. To be honest, it was hyperexcitable bilaterally, but more significantly on the injured limb. So we did something interesting in this group, in the same study. We then put them in a semi-recumbent position, and what we did is we applied a passive, pain-free tibial translation to the joint. You know the ACL prevents anterior translation of the tibia on the femur. So what we did is we used this KT1000 and applied that, and we were monitoring hamstrings in real time just to make sure there was no active hamstring activation. And what we found was applying a passive, pain-free stretch ramped up the response 2- and 3-fold. So the take-home point on that was maybe walking around on a loose joint may be maintaining this central sensitization, even though none of them complained of pain. And so that's kind of our take-home on that, because you may wonder, they had the injury, why would that be sustained? And that may be an answer to that. Okay, so again, that was my brief mention of some laboratory measures. I want to talk a little bit more about some of the clinical features of chronic pain. And some of these include heightened intensity of pain. Now, that's probably not surprising to this group, because if you think about some of your prognosticators, for example, after whiplash, an indicator of poor prognosis can be if they just come in with heightened levels of pain. And so that fits, that's a part of that central sensitization pattern. Spreading of pain is also an indicator of central sensitization, and we'll talk a bit about secondary hyperalgesia. The pain ramps up easily. We'll also talk about temporal summation, the impaired ability to inhibit pain, latent pain, and then just briefly on hypoesthesia associated with pain. So again, with secondary hyperalgesia, you can have a spread of symptoms. I define it as a regional spread of symptoms because I feel like some people with back pain can have spread into the limb, or with knee OA, their limb may be kind of sensitized, but their upper extremities are fine. So I call that a regional central sensitization. But then you can also have widespread central sensitization. And if you think about your typical fibromyalgia patient, that's kind of the classic example of widespread central sensitization. And one of the tools that we've started to use to look at this is pressure pain thresholds. Is anyone using that in their clinical practice now, using algometry? A couple people, yeah. And so we're starting to see that a little more and more in the clinic. All this is, all an algometer is a force transducer. So we've often palpated your patient and said, is that painful, is that painful? All this does is give a number to what you've been doing already. And so the classic way to measure that is threshold or how much they can tolerate. I've never used pain tolerance, FYI. But I've only simply used thresholds. So tell me the moment this turns from pressure to pain. So we'll talk a little bit more about that. The other measure, though, is allodynia. Allodynia is defined as pain with a non-noxious stimulus. This is typically measured cutaneously and in a dynamic fashion. You see them using the little brush there. And what we found is that mostly happens in the area of most pain. And so the thinking is that if there's not been any skin damage, stimulating receptors, cutaneous receptors with a brush should not be painful. If that is painful, that's often an indication of central sensitization. All right, I always throw this slide in because, just to talk a little bit more about secondary hyperalgesia. Imagine if you're baking cookies and you burn your hand. So the area in the bread is where you've burned your hand. But if you've ever noticed that around the burn, that tissue is also very sensitive. Now why? That tissue did not get burned. Well, that is an area of secondary hyperalgesia. So one more example, and then I'll talk about what is this mechanism. So here's a study by Bajaj. This is Aaron Nielsen's group in Denmark. And what they did is they took a group of people with knee OA and they compared it to a control group. And what they did is they injected the TA muscle with hypertonic saline. And so what you see is in the first, legs, that's right off the bat, immediately after the injection, and you can see that they have bilateral symptoms, but look at the group with knee OA. They have a wider spread of symptoms. Now at 2 minutes, that spread of symptoms is starting to decrease quite quickly in the healthy controls. Not so much in the knee OA. Their symptoms last longer. And then at 5 minutes and at 10 minutes, you can see how that plays out. Now, there's a couple things here. And I think for the clinicians in the crowd, here's the key. They induce pain at the TA muscle. There's nothing wrong with the TA muscle in these people with knee OA. So they induce pain at a site, not at the knee, but yet you can still see they get this widespread pain that occurs with that. And so the key point is, I think that sometimes it can be very confusing to the clinician when they're doing a treatment outside of the joint of interest, and they still get winding up of symptoms. We need to really think about this secondary hyperalgesia and how that feeds into the system. So what is that mechanism behind that? Well, it's called heterosynaptic facilitation. And so if you look, I don't really have a pointer here. Sorry about that if I've been smart. Now, if you look at the top square, say you've got your ligamentous injury. How about if I just point? Will that, can I do that? All right. So you've had your ligamentous injury, and those fibers, nociceptive fibers, are sensitized. They feed into the spinal cord, and those fibers that it connects with will also be sensitized. That's homosynaptic facilitation. However, adjacent to the injury are other fibers. They can be non-nociceptive or nociceptive, and their input to the spinal cord is also amplified or facilitated. And so they call that heterosynaptic facilitation. And so that's why you can get this spread of symptoms outside the area of injury. And Eric Nielsen will often say, with chronic pain needs to be treated because if not, that spread will continue to spread. That distribution will continue to spread. And then, so these are mechanisms not just behind secondary hyperalgesia, but also behind allodynia. And so just to give a clinical example, how might I use pressure pain threshold? Well, back to the knee injury, we might use our pressure algometer and get a pressure pain threshold at the knee joint line. And then we would compare that to the opposite limb, or maybe to healthy controls. If they have a spread of symptoms, we might also look at pressure pain threshold within the area of secondary hyperalgesia and compare it to the opposite limb. And then they often look at a site distal to, in the opposite extremities. And so it can be at the hand. And so the thinking there is they're looking for widespread hyperalgesia. And so, and that would be just the opposite if you had someone with whiplash. You might get the TA muscle just to see, is there widespread changes occurring here? Okay, a little change of gears, and again, I said just a couple slides on this because this is of interest to us and an area of research that we may expand upon. The thinking is that with chronic pain, you can also sometimes get hypoesthesia in the area of most pain. And they kind of talk about it like a reverse pain gate. So, your gate control theory, the whole idea is you have pain and you kind of rub the area of pain and that gates the pain. Well, sorry, I'm blanking on his name. Hello, he's at Northwestern. But he suggested that this is almost like a touch gate. His name will come to me. And the thinking is that the pain is gating non-nociceptive input that's coming in, so that these patients may feel less non-noxious input from the area of most pain. And we've looked at this cutaneously with mechanical detection threshold using monofilaments and also vibration detection threshold. And so you may think, well, does that really matter? Well, one thing you'll notice with people with both acute joint injuries and people with knee OA is that they often feel unstable. Now, that could be a mechanical instability that they're feeling, but it could be that they're getting almost this, like I say, this touch gate, and they're feeling the sense or perceived instability. And so in this study by a former student of mine, Alicia Kovcek, she looked at QST measures and instability in persons with moderate to severe knee OA while doing a step task. And our findings were that there was hypoesthesia both to light touch and vibration at the knee. But the interesting thing was that this was correlated, there was a correlation between this perceived instability with the step task and vibratory sense while negotiating a step. So we think that there's definitely more work that can be done here, and there definitely have been other larger scale studies with that. Yeah, question?
Yeah, I wanted to ask a question. So I do a lot of EMGs.
Yeah.
And so sometimes I'll get referrals for patients that say, well, they've done this in their hands, but they have a lot of pain in their shoulder, for example.
Yeah.
And then I do the electrodiagnostic study, it's normal.
Yeah.
But they still have this numbness or, is that sort of?
Well, we don't know, to be honest, but it could be. And because we see a lot of those patients too, and then we will, our big push is neuro exam, and maybe even the neuro exam is negative. There's no myotomal changes, no reflex changes, and no sensory loss. But they still say they're feeling, the sensory changes or dysesthesia sometimes. And so we can treat at the neck, and that can dissipate. And so, again, thinking mechanistically, if you think that this chronic neck pain is starting to cause this referral, then that kind of fits with that. So thanks for that question. Okay, a lot of people would argue that the measures I've talked about so far are static measures, meaning that the person is lying there statically and you're finding where the deficit is. Some people would argue that we need to provoke the system and see how it responds. And so these are called dynamic measures of central sensitization. And the two we'll talk about are conditioned pain modulation and then temporal summation. And so I like this quote by Wilder Smith. He said, these inhibitory mechanisms, these are our body's adaptation of incoming nociceptive information to momentary as well as long-term circumstances and needs. The key factor with that is that it's a dynamic process, and that in a couple ways. It's dynamic in that your body needs to respond to a painful input, and it's also dynamic in that it's not always functioning perfectly. Say you've got a student that's been studying for 3 days for exams, and they say, oh, I just hurt all over. That is an impairment of their descending pain inhibition. Or if you've got the flu and you ache all over, same sort of thing. And like I've mentioned several times, there's definitely evidence that impaired inhibition is related to sleep impairment. And so we have ways of measuring this, and this is through conditioned pain modulation. So what we do is we get baseline measures, and one measure that we've used is pressure pain threshold. So we might look at the knee joint line, and they can take 10 pounds of pressure before it feels like pain. What we then have them do is put a distal body part, and if it's a knee, we put their hand in ice water. Or they'll sometimes put a painful blood pressure cuff on them. One thing you've noticed that all my studies are painful, FYI. So they put their hand in ice water, and then what will happen after they take their hand out of ice water is that when you apply the pressure pain threshold, they can now take 15 pounds of pressure. That's a normal response. That's your body responding to that painful input and inhibiting it. And so that's a good thing. That's a healthy response. But what we find with certain painful populations, knee OA, hip OA, chronic patellofemoral pain, some studies with fibromyalgia, that these persons don't inhibit pain. In fact, their pressure pain thresholds will often go down. And so they have a problem with pain inhibition. So that's the other side of the coin I was talking about of central sensitization. I throw this in because my latest craze is exercise-induced analgesia, and probably my next direction with studies. But here's the study by Noggle. They suggested that in the clinic we could do a 3-minute submaximal isometric hand grip exercise, and you simply look at pressure pain threshold pre and post, and that would be a very easy indicator clinically if people have impaired pain inhibition. So the other measure I mentioned was temporal summation. And so basically what they're doing, this is a kind of a clinical correlate of the wind-up phenomenon. And so they are applying a stimulus typically applied at 1 hertz, 1 every second, and they they simply get an indication of how pain ramps up. And so they ask the patient every 5 seconds, tell me your level of pain. And really, you can see that the slope of that change is an indication that central sensitization might be present. I've not done these type of studies, but you will see these in the literature. So this is another way of looking, a dynamic measure of central sensitization. I always argue, because we, as physical therapists, we do manual therapy, and when it's performed wrong, manual therapy can be a form of temporal summation, meaning we can ramp people up by some of the treatments that we do, as well as sometimes as down modulate. So we have to really be thinking about the person in front of us and what the status is of their nociceptive system before we make that choice in treatment. A few slides about, now I'm going to talk about physical therapy management, but before I talk about that, I just want to bring up this study by Rice et al. In 2015, because a very common medical treatment for knee-OA is joint aspiration and corticosteroid injections. So I thought this was an interesting study. They looked at the flexor withdrawal reflex excitability before and after treatment. And so what you can see here on this graph is that the baseline response, and then how that there was a significant increase in that threshold after aspiration, okay? But then they inject with corticosteroid, and you can see at day 5 and day 15 that reflex response kept going up, meaning it's a sign of diminished central sensitization. However, perhaps even more interesting was the fact you can see that joint torques also went up correspondingly. And so, again, this kind of feeds into the thinking that with that excitability of that nociceptive reflex, that may be feeding into quadricep inhibition in this patient population. Another study is just simply, there's been a couple papers that said, hey, total joint replacement can also be effective in normalizing condition pain modulation. And so, again, this is a part of that approach to really taking a pain mechanisms approach to musculoskeletal care. And the point is like, when is the right time? If you're going to get a joint replacement, what's the best time to do that? And I still think that's kind of up in the air, and there's still questions on that. So what about manual therapy? That's kind of the bread and butter of any orthopedic physical therapist. We know that there's been beneficial effects of manual therapy, especially when it's been applied with exercise. And then a recent RCT by Abbott demonstrated an independent contribution of manual therapy for knee-OA and treatment. So, yes, manual therapy is quite valuable in our persons with knee-OA. And so here's a study that we followed up with, and we got baseline responses of that nociceptive reflex, and then we applied an oscillatory, non-painful manual therapy technique. Now, we based this a lot on some of Kathleen Sluka's work out of Iowa, and what she had done is look at the reflex after inducing an injury in a rat model. And then they took the little rat's knee and they mobilized the knee for about 9 minutes, and then they looked at the reflex again. And I said, well, if they can do that with a rat, I think we can do that with some people. And so we followed up as well, and we also found a decrease in that excitability of that reflex, which is an indication of a decreased central sensitization. And again, you've got to understand our history. A lot of people thought this was hoodoo or voodoo, I guess is a better word, and like, what are you doing? And we were trying to say, hey, there is there's probably a central component, a hypoalgesic effect to this. And then in a more recent study, we also looked at the effect of joint mobilization on condition pain modulation. Because remember, because we were able to decrease the excitability of that reflex, that still doesn't tell us what happened. And so what we found, and I won't kind of go into too much of the details with this, but what we found was that in these people, in this select group of people with NEOA that had impaired conditioned pain modulation, we were able to apply manual therapy, and that conditioned pain modulation improved so that they had better descending inhibition. So this is likely the mechanism of how they were able to decrease excitability of that reflex. So, and then what about exercise? Well, we are probably all aware of the physical activity guidelines for cardiovascular health. I'm not going to go through these, but that's important for all our patients. But I think that physical therapists have had this idea that they were exercising for the following reasons: to get stronger, to improve endurance, motor control, function, power. However, but what about for pain? They think that you got stronger and that's why your pain went down. But maybe that's not the case. So let's talk a little bit about that. Well, you know, the problem in society is this sedentary lifestyle. And so what happens with that? Well, adipose tissue causes an increase in TNF-alpha, increased C-reactive protein, and that promotes kind of this low-grade systemic inflammation. On the other hand, we know that regular, and this is the take-home point of the lecture, if you will, regular physical activity prevents development of chronic muscle pain and exercise-induced muscle pain. So if everybody is exercising, then chronic pain will not be a problem for us anymore. So it's the easy and also the very difficult answer to our problem, if you will. Yeah?
Answering, is there a difference between subcutaneous fat and visceral fat when it comes to inflammatory side effects?
Oh, I'm not sure on visceral fat because what I was reading on is subcutaneous fat. But my guess is no. But I'd have to check on that.
There's no difference?
Yeah, that there's not a difference. But I'm not sure on that. I'd have to check on that. What I was reading on was definitely subcutaneous fat.
I thought I heard or read that there were more inflammatory side effects
From the visceral fat.
from the visceral.
Yeah, it definitely could be. It definitely could be, yeah. Yes, that's the next slide. So good point. So our next couple slides. I'm a couple slides from there. So how does it prevent the chronic pain? Well, it reduces, this is all, you know, we talked about central sensitization. Exercise reduces phosphorylation of that NR1 subunit of the NMDA receptor in the central nervous system. And so the key point is, if you're exercising a lot and you have an acute injury, that will not have any effect. You're going to experience acute pain. But what it will prevent is that development of central sensitization. And so really, physical inactivity is the risk factor for development of chronic pain. So what happens with exercise? Well, muscle produces IL-6, inhibits this fat-induced TNF-alpha production, stimulates production of IL-1RA and IL-10. IL-10 is critical for exercise-induced analgesia. With exercise, there's both peripheral and central effects. You know, just muscle, I mean, some of these are obvious. Muscle contraction disperses inflammation, it restores normal joint movement, removes the mechanical drivers of pain, and again, it increases that expression of endogenous analgesic substances in exercising muscle. Oops. And then central effects, we know that beta endorphin release activates your descending inhibitory pathways. There's a positive effect on mood, reduction of stress and depression. But there's also non-opioid mechanisms. There's serotonergic inhibition. And then this Dietrich and McDaniel article, they kind of talk about endocannabinoid release. they suggest that the runner's high is more like marijuana rather than opioids. I don't know on that, so I'm just saying that's their suggestion on that. Okay, so what kind of exercise are we talking about? There's not been a lot of studies on resistance exercise, I'm just saying. But what there has been more on is aerobic exercise and isometric. So those are the two we'll talk about briefly. So in this study by Hoffman, they looked at the difference between 10 minutes at 75% VO2 max, 30 minutes at 50% VO2 max, and 30 minutes at 75% VO2 max. And that's where they found the best effect. So they're recommending that you got to exercise at least 10 minutes at greater than 50% VO2 max. And so, again, that's a recommendation on that. And again, I think a lot more work can be done here. On the other exercise I want to mention is isometrics. Now, I mention this because physical therapists use isometrics all the time, and then they wonder why it's helping. Well, one of those reasons might be because it improves pain relief. So Holger Beemit's up at Marquette, and she did the study. She looked at isometric contraction at 25% maximum voluntary contraction for 2 minutes, 25% MVC held to task failure, and then 80% MVC held to task failure. And the best was low-level contraction held for long duration. And so that can be the treatment in itself, just doing mild isometric contraction held for long duration. I just have 2 slides on this because, I think neuropathic pain is very difficult to treat. There's been several studies on aerobic exercise in an animal model, and they have shown the prevention of centrally mediated pain, both with treadmill exercise, also with swimming. And I'll just mention this study, and this was in a group of persons with painful diabetic neuropathy. They didn't just have diabetic neuropathy, but it was already at a painful point. They took 14 sedentary individuals, 16-week aerobic exercise program. At the end, less pain interference, but pain intensity unchanged. So their point being is we need to catch these people before it becomes the painful neuropathies, because that's when it gets difficult to treat. So in conclusion, I think that, at least in rehabilitation, we have a lot of modalities that we thought were working for one reason, but maybe they're working for reasons that we hadn't considered before. And so I think that there's a lot of research to be done to look at the best practice for our persons with chronic pain. And then the last thing I'll mention is with IASP, they have put out, I'm an educator, so, we need to advocate for these educational guidelines in our educational system. So these guidelines are out there, and I know, at least in physical therapy, that that's coming to the floor at our national meeting, that we accept those for all DPT education, because all physical therapists need to be kind of rethinking and all physical therapists and all medical practitioners need to kind of be rethinking how we approach chronic pain. Thank you very much. Happy to answer any questions if there's.
We have a few minutes for questions. Anyone?
Yeah.
This is less likely to occur in the laboratory, but certainly more likely to occur in clinical care. There are many factors besides what's going on physiologically that result in pain before, such as can't pay the gas bill,
Yes.
dog got run over. I do think oftentimes when we ask people how much does your knee hurt, they tell us about their suffering.
I agree.
I don't think they always differentiate the divorce from the knee.
I totally agree. And I only alluded to that early in my talk that, some of our pain measures are probably not getting to the issue. And so we need to really up our game on how we're measuring what's going on with the individual in front of us.
And I do think you were saying that really the focus maybe should be on function rather than it's more subjective report of pain. Because when we're treating function, then we're in a very measurable environment that we have a lot of tools for and we have a lot of things to think productively about.
Yes, so definitely function is a part of that, but there's also, with this trying to look at the pain mechanism. And I mentioned today from a physical therapist point of view, but you'll see the neurologist using various medications to just get at the mechanism of what's going on versus, using lidocaine patches versus, because they say, oh, this is what's going on. We can address it directly in this way. And so the more I read on that, I'm seeing more and more on that. But you're absolutely right that function, overall function, and is important. And then I mentioned pain interference is really huge because sometimes I've had patients in front of me that I thought to myself, I'm in more pain than you are right now. And have you ever felt that? Anyway, but my pain doesn't interfere with my life. It's like, yeah, I got some neck pain. I had a little whiplash injury. But, it absolutely doesn't interfere with my life. How much it's interfering with their life may be a whole different story. So, yes.
So, before the talk, I was mentioning to you 81-year-old medial compartment of the right knee. Now, the other compartments of the other knee are the same age, but I think of pain when I'm doing something, if not good, at least useful, because it tells me you need to load that knee a little differently, maybe a little more outgoing, pronate the foot a bit and load that lateral compartment or a three-point brace or something. If I understand you, doing exercise to decrease the pain isn't going to interfere with that useful signal.
No, I don't think it does. You're absolutely right that pain's a normal response, and even peripheral sensitization or central sensitization is a normal response to tell us to get off that limb. However, I think sometimes with a sedentary lifestyle that we start walking and we say, oh, my medial knee, they hurt. I better stop walking. But if I just keep walking for a week, then all that's gone. And so what's the cause of that? I think it'd be really hard for me to stand up here and say why that happens, but there is a pathway there. And is inflammation the driver of that pain response? And does exercise help diminish that? That's sort of my thinking on that. Does that make sense?
Yeah, it would never occur to me to stop walking.
Yeah.
Just walk differently or
Yeah.
keep reducing your own body weight or figure out ways to have that back to life.
Yeah, and it doesn't to you, but to a lot of our patients, they say, oh, it hurts, I shouldn't do it. And I think we're kind of to the point where like, no, let's just change, let's back it up and kind of work up slowly. Even with fibromyalgia, which I really haven't talked much today, but there's even evidence with fibromyalgia that if it's done right, exercise can be a valuable treatment. Yeah.
So you mentioned kind of the dichotomy there between, I'll call it overuse injury from a certain population versus maybe the sedentary population where it's underuse. And so, and I appreciate your educating, new providers. How are you teaching providers not to apply the same approach to perhaps different patient
right.
profiles? That sedentary individual versus that overuse, maybe athlete.
Well, I still think I'm not to the point where, excuse me, I'm not to the point where I think I'm going to take a whole hands-off approach with chronic pain, and there are clinicians out there that have taken that. I still think I need to know, is there a peripheral driver of this problem? And we kind of talked a little bit about maybe with your back, that maybe that's part of the driver. And is that something that, can you treat that? Or is there a top-down driver? They're afraid of moving. And so someone needs to address their fear of movement or fear of pain. And so we're, again, going back to what you had said, is that you have to look at the whole picture, both a physical exam and everything else, and kind of pick out what's going on here. Or that sleep's my other big thing, Are they not sleeping? You'd be surprised if you start asking people how they sleep. It is amazing. Like, oh no, I only sleep 4 hours, and I've got the TV on all night, and I'm just like, I was like, there's the problem. So, any other questions?
Body weight, too.
Oh yeah,
The
yeah.
BMIs in my patient population go up in the high 60s. And so they can't use the usual gait mechanisms that they're walking as a on posts because their knee would give away to the
Yeah, that's right.
strength if they walk normal.
Yes, it's multifaceted, and so exercise is the answer. But again, like I said, this hasn't even been my area of research. But the more I'm reading on this, I really think that's kind of a future, a future area that I'd like to be involved with. So, yeah.
And I'll just mention, when I'm working with a colleague, the inflammatory processes affect a whole bunch of things. I mean, it contributes to some types of dementia.
Yeah.
It contributes to other processes. That whole inflammatory balance is such a fine line and easily moved in the wrong direction.
Yeah, and again, not my area of research, but I know that there are those people that are there's people that really overdo it, and then there's moderate exercise, and I probably shouldn't even talk about this because, like I said, I'm not my area, but there's some evidence that they kind of have many more problems when they're overdoing that. So.
Thank you very much. Thank you. And I know Dr. Courtney will be here for a little with us, so if there are other individual questions, feel free to pop one up. Thank you.